the push now is to change it to acceptance, because being aware of autism is all well and good, but until we really accept people with autism, we're really not doing them any favors. So acceptance means sort of understanding and changing the world around us in order to help people with autism, instead of sort of realizing that they have autism and expecting them to accommodate us. So that's why the push all of a sudden in the last couple of years is to change it to Autism Acceptance Month. So what is autism? So it's called Autism Spectrum Disorder, or ASD, and the CDC says that it's a developmental disability caused by differences in the brain. So some people, like my son, might have an underlying genetic condition that sort of causes autism or causes behaviors that we see in autism. And so for him, when he was 4, we sort of went after the autism diagnosis because people were a little more aware of what that entailed and how to help him. But some other people who have an autism diagnosis don't have any underlying genetic disorder. We do realize that it can run in families, and there are a lot of similarities between different people in families, but there's no known cause for autism. But people with autism may behave, communicate, interact, and learn differently than the rest of us. And so it's diagnosed by looking at all of those categories: how are they behaving in a group of people, how are they behaving alone, and we'll talk about some of the behaviors that are very common too. How do they communicate? How are they interacting? One of the most common things that we see is lack of eye contact. So a doctor will look at all of those, and they do use, they have screenings that ask the parents, to fill out a sort of a checklist to diagnose it, but also the doctor will look at, different kinds of things firsthand. So sometimes it can be diagnosed before the age of 3, and they're getting better and better at diagnosing it earlier and earlier, just because we know sort of what to look for sooner. But sometimes people are diagnosed as adults. What we see a lot of is a child diagnosed with autism, and you see a lot of the characteristics of a parent, and then the parent later goes and ends up with the same diagnosis. So more and more adults are being diagnosed as well. Right now, the diagnosis rate is 1 in 54 people. It used to be, when I started doing these trainings, it was 1 in 68 and has gotten more common. That's not to say that more people now have autism than had it before. It's just that we're getting better at diagnosing it and realizing it. But it does occur 4 times more frequently in boys than in girls. That's the diagnosis rate. It doesn't necessarily mean that more boys have it, but it sort of manifests differently, and we typically see different behaviors in boys than we see in girls, and I'll point some of those out as well. So these are a lot of terms that we deal with a lot in special education, and specifically for people with autism. So the Individuals with Disabilities Education Act, or IDEA, is a federal law, and that requires free, appropriate public education to be available to all children. So free, appropriate public education we call FAPE. So that means that all children, regardless of disability, have the right to an education at the public expense. So they shouldn't have to go pay to be in a different school or to get a different service. That should be through the public school system. There are different parts to IDEA. Part C is school age. So that's age 3 until their 22nd birthday. And Part B covers birth to 3, or early intervention. In Connecticut, we call it the birth to 3 program. So basically, if a child is diagnosed, if a baby or up to 3 years old is diagnosed with any kind of disability, the state sends in therapists, whether they need physical therapy, speech, occupational, or a special education teacher, or any kind of behavioral therapy. They come in the home and they work with the family, usually weekly, but depending on the needs of the child, it could be less frequent or even more frequently. And from the time that they enter the program until their 3rd birthday, they provide that free education. At their 3rd birthday, they then transition into the public preschool. So they would have to qualify. So they would do some evaluations in that transition, and then the birth to 3 would go to the parent with them for the meeting to get them into the preschool at the public school. And typically in Connecticut, those preschool programs also have typical peers. So they have kids that do not have disabilities in those programs, so that the kids with the disabilities can be together with their same age peers. And so IDEA covers all academic and therapeutic interventions. So if somebody needs special education services or one-to-one instruction or one-to-one support through the day, it covers that. It also covers physical, occupational, and speech therapy during the school day, as well as any other kinds of modifications or accommodations. So if they need a special kind of seat, or if they just need extra time for a test, it covers all of that as well. So free appropriate public education, I touched on quickly. It's guaranteed by federal law. So it requires those special education services at the public expense to meet whatever the child's needs are. So it's not to say, well, we put all kids in, in this program. It's supposed to be specific to each individual student. Special education falls under IDEA. So basically that means educating students in a way that provides any accommodations to address their individual differences, disabilities, and special needs. So like I said, that includes instruction and therapies and anything specialized, including transportation. If a student needs an accessible car to transport them, or they need an aide on the bus, or they need a van with a monitor to provide some extra support, that would all fall under special education services. The least restrictive environment, or LRE, means that any child who receives special education services should be in the same classroom as other kids without disabilities as much as possible. So for each child, that's different. Some kids can be a whole day in a regular education classroom. Some kids can be there but need some support, and some kids will pull out for certain services, but it means that they should be in that regular education classroom as much as they can tolerate, as much as they can stand it. It's not a place. The special education classroom still does exist, but like when I was in school, it was a classroom down the hall and you never saw the students who were in there. Now it's, there's a push in, and you want kids with and without disabilities to be together, to learn together, and to interact and really integrate into the program. So there are still special education classrooms, and students do still pull out, or some kids may need to be in a special education classroom or even a special education school for most of the day. But the goal is, as much as possible, to have that student with their same age typical peers. So the IFSP is the Individual Family Service Plan, and that is for the birth to 3 program. So that's for early intervention, and that's all those therapies that come in. So they write, it's multiple pages with lots of details, but with specific goals for each individual child. So it involves the entire family. So that's why they do the services in the home. What they ask the parents, what they want to see. They incorporate any siblings that might be there or caregivers into the therapies. And they write that all down, and that service plan lists the goals, how they'll accomplish the goals, how frequently they'll come, who will come, when they'll reassess or reevaluate, and then any issues that come up. And every year they'll do all new evaluations and redo the IFSP. And then the IEP is very similar, but that is the individualized education plan, and that's the school-based plan. So this is where there's sort of this disconnect, and it was for me as well. For families going from the birth to 3, the IFSP, where the family is integrated into the service plan, helps write it and is just involved 100% into this. individualized education plan where it's school-based, so you're not there during the day. You still do take a part in writing the plans, but you're not involved carrying them out, or you don't see them firsthand. But the IEP includes specific, measurable academic and therapeutic goals and objectives. It shows who will provide the services and the frequency and location of those services, and includes, like I said, transportation, also any kinds of specialized equipment or chairs or anything a student might need to help them get through the day, and any extra supports as needed. It is a legally binding document, so it's important to make sure that, you know, parents' voices are noted, and parents work together to write the IEP, which leads to the planning and placement team, or the PPT. So that's the group of people who get together and write the IEP. So it includes the parents and the student once they're old enough. And so legally, you know, we say about 14 years old, a student should start coming. But I mean, I've had students pop in and just, you know, say, this is what I want to do when I'm older, even at, you know, 10 years old, just to sort of put a face to all of these goals and objectives, and remind everybody that this is a person, that, you know, it's not goals on a piece of paper, it's somebody's life. So you have the parent, and a parent can bring anybody they want, and that's where I come in with parents to help them and sort of explain things and just be an extra set of eyes on everything. But they could bring, you know, a grandparent or aunt or uncle or cousin or friend or whoever they want to support them. It doesn't have to be somebody who, you know, even has to say anything. Sometimes it can be an emotional support person, because walking into a PPT meeting as a parent is very overwhelming. And typically the school will have anywhere between 5 and 15 people sitting on one side of the table, and the parent is then brought into, and, you know, you're completely overwhelmed, outnumbered, and can feel, you know, like you're really fighting an uphill battle. So we encourage parents to bring whoever they feel that they need to bring with them. And they're legally allowed to do that. It also includes a special education teacher as well as a regular education teacher. And this is important because the regular education teacher can kind of speak to the curriculum that all of the other kids the same age are working on. And the special education teacher can then, you know, say, well, this is how we'll break it down and how we'll provide the individualized instruction. There also needs to be a school administrator in the PPT meeting. And this is basically the money person. So it can be a school psychologist, it can be a principal, it can be somebody on the district level, but it has to be somebody who in that meeting can say yes or no to anything that comes up. So that we don't have the situation where the parent is asking for something and then they're saying, well, we'll have to get approval. Either it's approved in the meeting or it's not. And then there are steps you can take after that if you want to appeal a decision. And then, like I said, the student can be included. Also, if a student has a paraprofessional support through the day, we like to see the paras there, because they're the ones who are with the students all day long and who kind of know the ins and outs of what's going on. So that the PPT meetings are required at least yearly, with reevaluations, complete reevaluations for special education every 3 years. It's called a triennial evaluation, and that's where they look at everything. They do comprehensive evaluations for anything that may affect the student during the day, but that's every 3 years. And then a parent or a teacher, if there are any concerns, is legally able to call a PPT meeting at any time to get everybody together to discuss whatever's going on or what they can do about it. There's a lot of backup because of COVID where evaluations didn't get done or meetings got pushed, but legally they're supposed to be within 1 year. And it should be easier to conduct the meetings just because we're able to do it on Zoom now or on, you know, Google Classroom virtually. But there's still some, you know, pushback from a lot of the school districts. They'd rather have people there. And I know that, you know, it can be difficult to schedule those, but they are legally required to do them every year. So PPT meetings are for special education determination, and that all falls under IDEA. But for students who don't qualify for special education instruction or an IEP, there is another option. If they qualify, it's called a 504 plan. And it's from the Rehabilitation Act of 1973. So this was before IDEA. And that just allows accommodations for a student to access the curriculum. So it provides any tools that are necessary. It doesn't change the curriculum, like an IEP may change a goal, or different, they may take alternative tests or something differently than the regular curriculum. But a 504 allows a student to access the regular curriculum. And in Connecticut, not all states, but in Connecticut, it also includes therapies. So a student could qualify for, say, physical therapy, but doesn't need other special education instruction. And so they would have a 504 plan that would say this student gets therapy weekly for 30 minutes. The difference between the two, so IEP provides tools and supports to adjust the curriculum, and then a 504 helps the student access the regular curriculum, but it at least provides something for students who may not need a full IEP or special education instruction, but they can still get whatever therapies they may need or any other accommodations that they may need. So accommodations includes anything that adjusts the environment. So these are what would fall under a 504 plan, any kind of adaptive seating or extra time to complete tasks or special kinds of pencils, anything that allows the student to access the curriculum, where modifications adjust the curriculum. So alternate tests, shortened assignments, anything that's not what the general education students are doing. Another term we deal with a lot with autism, not a legal term, but it's nonverbal. And it's just that somebody doesn't speak verbally. That doesn't mean that they are not communicating. Most people who are nonverbal can communicate just fine. They can write or type. They can use a communication board. They can use sign language. So there's still communication. It's just that it's not verbal communication. The sign board that they use is a PEX board, or Picture Exchange Communication System board. And it's just their way to sort of point at words or common requests that they would use a lot. And they can be modified. Lots of times now they're on tablets, but sometimes parents will print out a page with the most common requests. So I've seen people make them into like a bracelet. And if they're going to, say, a water park or something, and it'll say like, I need a break, or I'm hungry, or I have to use the bathroom. And so the person can point to those, so the caregiver knows what to do with them when they can't have, the full PEX board with them. Another communication issue we see with autism is called echolalia. And that just means repeating words or phrases. It could be repeating something that they've heard a person say, or something that they've been taught to say, or it could be repeating something they saw on TV. And it's not used appropriately often. So, they'll say, if you say, hello, how are you? They may say, hello, how are you back to you? Or just say some random line from a movie that they just happen to be watching. It's still communication in a lot of ways. It's a good effort, but it's just not the words that we would think of as being the most appropriate words at the time. And then another thing is activities of daily living, or ADLs. So this is anything that someone would do every day. And this is something that's worked on in these therapies in school and at home. A lot of people do, they do seek out outpatient therapy in addition to what the person is receiving in school or through the state, because it's never enough. Staff at schools are stretched thin, but also they're working on things that affect life during school. And so they're not working on activities of daily living as much as most parents and caregivers would like to see. But so ADLs include dressing, feeding, cooking, toileting, taking care of themselves, anything that you do every single day that you probably don't even think about, but they often require very specific and repetitive instruction. And so that's something that can be worked on in therapy or, with a specialist in the home. So that's a lot of information. I don't know if anyone has any questions about that, or we can, if you think of anything, just let me know. Okay, so this is an example of some appointments that we have to go to a lot for people with autism. So for example, my son has 8 recurring appointments per week. That's not that's just his standing appointments. So there's also specialists and regular doctors and regular life, but these are some of those appointments. So occupational therapy, or OT, works on fine motor skills. So your writing, your activities of daily living, but also sensory issues. And we'll get into those a little more too, but basically a lot of kids and adults with autism have issues with their senses. So they don't like touch, or they seek out touch. They don't like certain textures, or they do like certain textures. Different sounds could bother them, too much light or different kinds of light. So all of those sensory issues can be addressed during occupational therapy. And then, so those are the fine motor, but also gross motor would be physical therapy, or PT. So that would deal with any balance issues, running, jumping, strength and coordination, anything that's gross motor or bigger muscles are pushing those. Speech and language therapy is very common for kids and adults with autism. So, part of it is articulation. We think of, forming sounds and making words and what we think of as speech. But part of it also is just the muscles in the mouth, which can lead to eating issues, strengthening those muscles, strengthening, the tongue and other muscles in the mouth. And then the language piece of speech and language therapy deals with actual conversations. So, listening to people, having a reciprocal conversation where, you're appropriately asking questions and answering questions, going back and forth, looking at the person when you're talking to them, how to interact appropriately with others. So speech and language therapy covers a lot of different things, including feeding. A lot of kids with autism have issues with eating and different kinds of textures, or gag reflex, we think of it too. So they'll work on trying different foods, even if it's little bits of food, and then social skills as well. So some speech and language therapies will not be one-to-one. They'll be in a group setting, a small group, just to work on those social interactions. So feeding therapy would fall under speech and language, as well as social skills therapy. Applied behavior analysis, or ABA, is scientific. It's a scientific technique of behavioral management. So it focuses on very specific behaviors. So that could also include social skills or communication. It could be an academic issue, but it often is behavioral or hygiene, safety, living skills, managing behaviors. It's very intensive. It's typically done daily. They do use it in schools, but you can also get outpatient therapy, but that outpatient therapy is in the home, and it can be anywhere from 3 to 6 hours a day. So oftentimes, kids will be in school all day, and then we'll see an ABA therapist come into the house until they go to bed, to help manage the behaviors and sort of teach them the skills they need so that they eventually, hopefully, can manage the behaviors on their own. So that's extremely intensive and, takes up a lot of time for the child, but also the caregivers. And then the school meetings are frequent. Whether you have a PPT, an IEP meeting, or a 504 plan, you have often more meetings than other parents might have. You might have meetings relating to behavioral situations. Lots of kids with autism end up, they get overwhelmed and they end up in a restraint or seclusion, which is where either they've had to be physically held to keep themselves or others safe, or had to be removed from the classroom and put somewhere in a sort of a safe room by themselves until they're able to calm down. And so every time, every time that happens, the parents or caregivers are notified. And then if it happens 3 times, they need to go in for a meeting, and they need to reevaluate what they're doing and why these are occurring and what's happening. So those are just extra meetings that parents have to go into. Also, any transitions. So whether it's from early intervention into the school system, or from the school system into adulthood, or if there's any transition between elementary school and middle school, or middle school and high school, it requires more than just 1 meeting or 1 tour. It usually requires 3 or 4 or 5, just to get everything set and to meet the new team that will be taking over, and to prepare the child for a new school, giving them tours or information they might need through the day, just getting them familiar with their new environment. So that's a lot more than the typical parent would have for a student. They also have to review the program and do the reevaluations and sort of stay on top of everything. A lot of times, there's a lack of communication between home and school. And so a lot of parents spend a lot of time contacting the school, sort of chasing people down to say what's going on with this, or did they get their therapy, or what's happening, especially when the kids are nonverbal. Because the kid can't come home and tell them, oh, I didn't see so-and-so today. So there's, that on top of all of the other meetings and appointments. We also often have medication management appointments, usually every 1 to 2 months. If somebody is on medication for either their focus or behaviors, or anything else, we have to go in and reevaluate how it's working and if there are any issues. And with behavioral medications, there's really no way to know ahead of time if it will work or how it will work. And so it's sort of trial and error, which is unfortunate. And it's difficult to watch as a parent or a caregiver. Even as a teacher, if a student is on a medication, to watch out. Some of them will sort of put the kids in a trance, which is not what you want, because then they're not themselves. And some have no effect, or some will make the behaviors spike, and so it just escalates everything. And I'll try a different dose, or we'll try a different medication. So there's a lot of medication management appointments, which can be done through a pediatrician, but is often done through a psychiatrist, who can then sort of help with any other issues that come up, or refer to a psychologist, or try to talk through some of the issues or behaviors that we're seeing. And then a developmental pediatrician is often called in. Then they just specialize in developmental disorders. Sometimes people use them instead of a pediatrician, and sometimes people use them in addition to a pediatrician. It just depends on personal preference and your relationship with the doctor. So those are some of the appointments. There are also, specialists and, all kinds of the regular appointments we have with dentists and doctors and all of that stuff too. So the biggest challenges facing families with autism. So financial, the cost of all of these therapies and doctor's appointments is huge. Getting to and from the appointments, just on gas alone. If you need childcare for another child, or, you need somebody to assist you with somebody bringing them to the appointment, you have to pay somebody for that. If you need any kind of specialized equipment, if you need to do a training, or you need to hire an advocate, or you need some kind of respite care, that often costs, huge amounts of money. And there's some state aid, but there are huge waiting lists. So people end up paying out of pocket or going without. And, that's not something that we want to see, but that's the choice that people have to make. So there's a lot of financial strain on the entire family. Including siblings who maybe now can't do, a sport or something that they wanted to do because nobody can take them there, or they can't pay to do it. There's the physical challenges. So behavioral issues. Parents and caregivers get hit, get their hair pulled, get things thrown at them. You have to be on all the time. So for a lot of people who have kids with autism, and even as they grow into adults, it's like waking up to a toddler for 10 or 20 or 50 years. So there's a lot of, you have to be mentally aware of what's going on and right on top of them and supervising all the time. And then, with that and behaviors, you have to be able to at times either physically restrain or sort of be there right on top of them to make sure that they're staying safe. So there's a lot of physical strain on parents and caregivers as well. And then the emotional strain, I think, is probably the biggest, because I know for me at first diagnosis, it was, well, what's going to happen when I'm not here? And so there's a lot of worry about the future and who's going to take care of this person, who's going to make sure that they're safe, who's going to make sure that they're taking their pills or eating or getting their therapies. You worry about care, who you can't just go hire some babysitter you find online. You have to really know that that person is able to take care of them physically and understand that this person needs more support than the typical 10-year-old, or if your child is older or even an adult who still needs supervision, you have to have somebody who can handle that and can understand that. And then there's worry about just the development of the child. Oh, they're not making friends, or they're doing this and they said this and they're being taken advantage of. So there's just a lot of worry about the social growth and independence of that person as they grow and as we're no longer here to take care of them. And so that's probably one of the biggest challenges facing families, is just planning for the future. And there's no good way to do that. You can set up the money and think you have supports in place, but things change so frequently that it's really difficult to be 100% sure that everything's going to be okay when you're not there to do it yourself. So I talked about some behaviors that we see with autism. So these are some of the most frequent. So what we call stimming is it's a stimulation. So it's repetitive movements or unusual movements that we might see, or certain noises that people with autism might make. And it helps them to manage their emotions or to cope with overwhelming situations. So it's not always a bad thing, and we typically don't correct it unless it's a danger or extremely disruptive, because it is helping that person. But this is where you see rocking back and forth, or like flapping hands or arms, bouncing or getting up and pacing, hair pulling, either their own hair or someone else's hair, repeating words, or like clearing their throat or making a certain sound over and over and over again, rubbing or picking at skin, blinking frequently or quickly. But it's, like I said, it's only addressed if it's negatively impacting the person or those around them. And there is a purpose to it. It just, to us on the outside, seems like something different. But they are trying, they're trying to keep themselves from being overwhelmed. And so it's not necessarily a bad thing, even if it, to us, it looks, well, people are looking at you, or that seems strange. Another thing we see a lot are meltdowns, behavioral meltdowns. The thing to remember about meltdowns is that they're not temper tantrums. We all have temper tantrums, even as adults, we get upset about something, but it's a meltdown is an intense response to something that's overwhelming. And they're not able, it's a complete loss of behavioral control. So they're not able to control it. A meltdown will stop either because the person is completely exhausted and just can't do it anymore, or whatever is causing the meltdown, whatever is causing the person to be overwhelmed is removed. Whereas like a temper tantrum is usually for attention or to get something, and will stop either when the person realizes that they're not going to get it, or they've gotten what they wanted, and it's controllable. You think of like a typical 2-year-old, they're able to move on, but a meltdown is completely different, and they're not able to just move on. It's not what we think of as a behavioral issue. It's an overwhelming response, to circumstances that they're not able to control. Overactivity is extreme activity that's not on par with others of the same age. So this is where you see the bouncing and the moving and getting up and walking around. And this is also how we see autism manifested in boys more than girls, is this overactivity. We don't typically see girls moving as much as we see boys moving, even typical kids, but with autism. It could be a result of a sensory issue or overstimulation somewhere. But so they're trying to sort of keep calm by moving their body. Whereas shutting down is what we see more in girls. It's more of like an internal overactivity where they look like they're shutting down. Their mind is not focused on what they're supposed to be doing, but they're behaving. They're not up and moving around a classroom or a house. They're not running off. And so this, I think, is why more boys are diagnosed, because the outright overactivity is more noticeable and more disruptive than somebody sitting in their seat not paying attention. And so I think sometimes that gets overlooked in girls, because that's what we see it manifested more in, the shutting down and the internal, the internal overactivity. If it's not a behavioral problem, then people just sort of let it go. So these are the steps to help people with autism and their families. So recognizing, understanding, managing, communicating, and improving. And I'll go through each one individually. So recognizing a special need. So autism is classified as an invisible disability. So it's not something like somebody who uses a walker or a wheelchair. If you just look at somebody, you can't typically tell that they have autism unless you know certain behaviors to look for. And so it's harder to recognize that there is some kind of need. So you have to look for those subtle signs, right? You want to look for any kind of that stimming behavior, or eye contact when they're talking to you. And lots of times, we're all taught, look at me when I'm talking to you, look at me when I'm talking to you. But in reality, for people with autism, sometimes looking and listening is too much. It's too much stimulus. And so in order to listen, they need to not be looking at you. So forcing someone with autism to look at you isn't always, then they may not be listening. Because they're looking at you, and that's enough sensory input, that's enough coming in for them to deal with, and doing both is too much. Another way to look for an invisible disability or some kind of issue is watching how the person's family and caregivers and siblings interact with that person. If it doesn't seem to be age appropriate, it's probably because that person needs more support than other people their age. So just paying attention to those around can give you a clue that something is going on. You're not going to diagnose somebody, but at least you may need to pay a little extra attention. And then be aware of any possible sensory issues. So, lights or noises. If it seems like it's a little bright to you and somebody's having a hard time, maybe it is too bright. Or if there's, if someone's covering their ears, there may be a noise. And that's one of the things that we all sort of are able to deal with in our lives, is like certain noises or lights that, they could bother us, but it's more like, oh, we might notice somebody mowing their lawn across the street, but it's not interfering with our lives. Where somebody who has a sensory issue with their hearing, that, that may really be disruptive. And so it's kind of paying attention to any sort of sensory input that may be around you that you're not necessarily bothered by, but other people might be. So once you recognize that there's something going on, you need to sort of understand why. So you can't assume anything, and you can't write off a behavior. So you want to look at why the person is responding how they are. So that's where you're looking for the clues as to, are they covering their ears? Is it a noise issue? Is there some kind of light in this room that is different than other places? Because all behavior is a communication. So somebody, having a meltdown, there's a reason for it. They're trying to tell you something. And so it's not that they're bad or, they're misbehaved or their parents haven't taught them something. It's that there's some issue causing this. And so sort of looking for that issue. And even if you don't know the specific reason, just understand that there is a reason for it. And it's a lot easier as a caregiver to have patience for somebody when you realize that they're trying to tell me something. It's not, they're just causing problems and making my life difficult for me. It's they're trying to tell me something. I need to try to figure out what it is. So once there is a behavior, all you can do in the moment really is manage the situation. So if there's an immediate accommodation that you can identify, go ahead and do it. Whatever you can to alleviate behaviors, and you may not know exactly what that is, and that's okay. But anything you try that you think might help is worth a try, because if you're already seeing behaviors or there's already a meltdown, it's not going to get worse. So you might as well try what you can, to help. So if you think it might be a lighting issue, shut the light off, or provide a quiet place for somebody to sit, or give them options. You can do this or that. Having tools available. So lots of people with autism, if you know that they like certain things, having those available, like for instance, a beanbag. A lot of kids like to sit in a beanbag because they like the pressure on their body, and that helps calm them. Or just any kind of fidget tools, which doesn't have to be anything fancy. A lot of kids will use pipe cleaners and play with those just to keep their hands busy, and that's calming to them. Or Play-Doh, or kids who like to scratch and pick, sometimes Velcro to play with. So it doesn't have to be anything fancy, but just having those little things nearby to try is a good idea. As long as, you can provide, you want to keep them safe, obviously. And sometimes, that requires a restraint if you're able to do that. But anything you can do where you don't have to put your hands on and they're able to sort of calm themselves is better than, having a meltdown and you just standing there like, I don't know what to do. So once you've managed the situation and gotten through it, that's when you want to communicate. If it was really challenging, you want to talk about it. You want to talk to the person if you can, but also the family, and see, ask questions about it, because we don't know what we don't know. And one of the most frustrating things as a parent or a caregiver is people assuming that they understand, or that they know, or that, they've done what's best, when they never even asked what might help in the future. Because there are often things that the parents will tell you that, oh, I didn't think of that, or, it's something simple that you just didn't know to ask about. And so just saying, this was the issue, this is what was happening when it was going on, what could I do to try to avoid that? Because it's better to prevent it to begin with than try to talk the person down while it's going on. And so if the parent or caregiver says, well, those kinds of lights really bother them, or the vacuum cleaner really bothers, that they don't like that noise, then just don't use those when the person is there. So asking questions and then listening to the answers. Lots of times was, oh, this was bad, but I handled it, and just move on. But then you're not doing anything to prevent it from happening again. And so listening to what the caregivers say is really important. And then the last step is improving your response. So basically listening to those recommended techniques that the person who knows best has given you, and keep communication open. Lots of times, I know for me, I prefer usually email or text, just because I may have a screaming child in the background, or I may be in the middle of one of my millions of appointments, or, so don't be, if you call somebody and leave them a message and then they text you back, don't be offended, hey, you didn't call me, because it's probably just because they're not able to really communicate or think about what they want to say, because there's so much other stuff going on. And then you want to make sure that you integrate. So families with autism are often very isolated and lonely. They're not invited to events, not even given the option to say, no, we can't come. We often, because people assume, oh, they won't want to come, or it'll be too hard, or, any reason you can think of. We don't always say yes, or we might say yes, and then at the last moment say, sorry, we can't make it. And just understanding that the reason isn't you, the reason is that they just can't handle it right then. But to keep communicating and including is really important, because, we spend so much time at appointments or dealing with his behaviors that we don't get time to socialize for ourselves as caregivers. And then that also prevents our kids or, family members with autism from interacting with other people. And so the integration is not there. And so we can't, we talk about autism awareness versus acceptance. You might be aware that somebody has autism, and if you're not including them, then you're not truly accepting them or the family as a whole. So just keep trying. And just because you see something doesn't mean that the person is not enjoying what's going on. So for example, when my son was really young, he played soccer, and I say he played soccer. He went to soccer and sat and watched. And to the coach, it looked like he didn't want to be there, and he was not happy about being there and didn't want anything to do with soccer. But all week long, all he talked about was going Friday nights to, see his soccer team and play soccer. So just because what you're seeing looks like the person isn't enjoying it doesn't mean that they're not. And if they're coming back, then there's probably good reason for that. So I'm always available for, whatever questions you have. But the Mighty is a really great website. It's a blog, but it's written by anyone can submit, and they approve, certain posts, but it has different kinds of viewpoints. So you might be able to find caregivers of people with autism, or teachers, or friends, or people with autism themselves might write a blog. It's just really interesting to read different points of view. And then the federal government, disability.gov, has, all of the laws that are required. Autism Services and Resources Connecticut is the state resource center. And they do a lot of trainings as well. Or if you just have, a question here or there, you can always call them, and they're paid for by the state. So all of their services are free. They're a nonprofit too. And then Connecticut Parent Advocacy Center also is always available for any questions. So I know that was a lot of information. Does anyone have any questions?
Erin, while we're still recording, I wonder if you could answer some advice you would give us for an adult to adult interaction where perhaps the person may not know that they're on the spectrum. We hear that term, on the spectrum, a lot.
Yeah.
And I think, sometimes you can tell that maybe you're catching a behavior could be considered on the spectrum. What advice do you have for how we might manage some of those things when perhaps the person may not be aware?
So, I think just treating people as people, you don't even have to talk about autism at all, but understanding that there may be an issue. And if the person is not aware, asking them, because likely, they're living a fairly independent life, and not saying like, do you have autism, but saying, is there something I can help you with? Or is that bothering you? Or just, is there anything I can do to help you in this situation? Because you're right. And there are a lot of adults who, as kids, we thought they would be, considered more like nerds, is what is the term that used to be used, and didn't have a diagnosis, and now are adults, and we're seeing those behaviors. So I think just asking the person, they should be able to give you some idea. They may not want help, and that's okay, but at least then they'll know that the option is there.
And then I just have one more about if you would be willing to address some of the misinformation that's out there about how autism is caused.
Yes. So there's a lot of misinformation that it's caused by something in the environment, or it's caused by vaccines. That's not proven. It just is. And I think the sooner that we can accept that some people just have autism, and that's how they were made, and that's just what it is, the better off we'll all be. Because trying to blame sort of makes it look like there's something wrong with people, saying, and it's not something wrong. It's a diagnosis, and it might cause some challenges, but that's just life, and that's just what it is. And people are people no matter what. So, blaming vaccines or blaming something in the environment does no one any good. And it has not been proven to be true.